Hello and welcome to Health Professional Radio. I'm your host, Neil Howard. Thanks for joining us again. Going to be speaking with Dr. Jeffrey Cohen. He's joining us here from the Cleveland Clinic to talk about some highlights from the 8th Joint ACTRIMS-ECTRIMS Conference. Welcome to the program, Dr. Jeffrey Cohen, and thanks for taking the time.
Well, thank you for the invitation.
Give us a bit of your background and talk about your role there at the Cleveland Clinic, if you would.
So I am a professor of neurology at the Cleveland Clinic Lerner College of Medicine and a staff neurologist at the Cleveland Clinic's Mellon MS Center, where in addition to seeing patients, I also run the experimental therapeutics program, the clinical research program.
Well, let's talk briefly about MS. What exactly is it and who does it affect?
So multiple sclerosis is an inflammatory disease of the central nervous system. It typically begins in young adults. It's somewhat more common in women than men, like a lot of other immune diseases. And it, in most people, begins with a relapsing course. In other words, attacks of neurologic dysfunction, which can include visual problems, weakness in coordination, trouble with gait, balance, sensory loss. And in many people, those relapses, those attacks initially recover fairly well, but over time, people accumulate disability. And in many people, the initial relapsing course eventually evolves into what's called a secondary progressive course, where there's gradual worsening of disability, even independent of relapses.
So is there a known cause of MS?
Well, it's thought that it's a combination of things. In part, there's a genetic predisposition to multiple sclerosis. Most of the genes that have been identified as contributing to the risk are involved with immunologic function. But that appears not to be the whole story. There probably are some environmental factors, exposure to viruses and other infectious agents, particularly Epstein-Barr virus. And then some of it just appears to be chance. Something has to go wrong with the immune system, causing it to malfunction, and then it sets up what's thought to be a so-called autoimmune condition where the body's immune system attacks one's own tissue, in this case, the nervous system.
So a genetic predisposition does not guarantee the onset of MS, right?
Correct. It contributes to the risk, particularly probably a combination of genes. But that only probably accounts for 30 or 40% of the risk. Even in identical twins, sometimes one twin has MS and the other doesn't.
Now, I understand you're president of ACTRIMS. Is that correct?
Of ACTRIMS.
ACTRIMS.
So there's two related organizations. So ACTRIMS is a European organization interested in multiple sclerosis, and then we're the sister organization in North America. There also are a number of other so-called TRIMS organizations around the world. But we've had a long-standing relationship with ACTRIMS. We put on a meeting together every 3 years, and this year's meeting is in North America. One thing that's different about this one is this is the first time we're having a virtual meeting because of the current pandemic situation. We unfortunately are not able to meet in person. So usually it's a pretty big affair. We have 10, 12,000 people gathering to hear sort of the newest advances in the MS field. This year we're doing it virtually, which will be sort of a new experience for most of us.
Well, what are some of the highlights?
Well, so we're going to hear a lot about new advances in understanding the pathogenesis, the mechanisms that lead to multiple sclerosis, the pathology, how we can visualize the pathology using imaging, MRI, and other modalities. And then there'll be a great deal of discussion of new treatments. Both disease treatments that address the underlying immune abnormalities. We've made a lot of advances in that aspect of MS treatment, but there also will be discussions of treatments for other aspects of the disease, potential treatments for the progressive phase, which we think is more of neurodegenerative process, and then also symptomatic treatments and rehabilitative treatments to try to restore function.
How often is MS misdiagnosed?
Well, so when MS presents in a typical manner, it's often a pretty straightforward diagnosis to make. The issue is twofold. One is that over time, we've tried to make the diagnosis earlier and earlier as treatments became available, so that we could initiate treatment at as early a stage as possible, because we think that by preventing the damage early, that leads to a better long-term course. But that impetus to make the diagnosis early also leads to the potential for misdiagnosis. And the issue is that MS can produce a wide variety of symptoms that are common in the general population that are not specific to MS, things like fatigue, imbalance, trouble with concentration, bladder symptoms, and also sometimes other conditions can cause lesions on MRI, which may be mistaken for MS. So even with all our advances in imaging and refinement of the diagnostic criteria, misdiagnosis remains a significant problem. So there's been a lot of discussion about how we might address that, and ultimately it's going to require better, more specific tests for MS. MRI approaches, for example, that can distinguish an MS spot from the kind of spots we see with diabetes and hypertension and migraine. And then ultimately, a blood test would be very helpful. That's one of the problems with MS is that we mostly make the diagnosis by combining the information from the history, the physical, MRI, spinal tap sometimes, but there's no one test that proves or disproves MS. So that's still a big problem for us.
So as we move closer and closer to more personalized treatment for individual MS patients, I guess that is the huge takeaway in potential outcomes for them. Yeah.
Yeah. So there's a big debate in the MS field whether we should, what's our best strategy. We're now up to like 16, 17 disease treatments. And there's a lot of debate on what's the best way to utilize those treatments. One approach, which is sort of a personalization approach, as you say, is one starts with one of the less potent but presumably safer medications, and then change therapy until you bring that person's disease under optimal control. It would be nice if we could predict ahead of time which treatment an individual person might require. We're not there yet, and so there's a lot of debate about whether we just do it by trial and error, or whether we should just start with one of the more efficacious medications right from the beginning. So that's a big debate among the MS field: is what's the best overall treatment strategy.
We'd like to learn some more online about this upcoming conference. Where can we get some more information and learn some more about ACTRIMS as well?
Well, so one can go to the ACTRIMS website. If you just Google ACTRIMS, that'll take you right to the ACTRIMS website, and there's a link there to the virtual conference, MS Virtual 2020. There also are links on the ACTRIMS, ECTRIMS website. We'd love to have people join us virtually for the conference.
Well, I appreciate you joining us here on Health Professional Radio, and getting the word out should ensure that some people will be joining you for that virtual conference.
Great. Thanks, Neil.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Jeffrey Cohen. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au.